Alright, gang, there was a couple of things in the Wall Raven slides that I, per se, didn't see, but I want to make sure that you guys have an understanding of it. And so we're going to go over the exotic rhythms. So these are things that you might see once in, I don't know, about a decade. Well, not the pace ones. The pace ones you're going to see a little bit more often. So we're going to kind of really hit on those when we get to that. But let's talk about these guys right here. So these are ones, like I said, that I did not see in the Wall Raven slides that I definitely want to make sure that you guys have a firm and clear understanding of. Alright, so the first one is sinus arrest. Simply putting it, we talked about sinus arrhythmia. Sinus arrhythmia is usually caused by issues with the breathing. And so what happens is it kind of extends out. In the case of sinus arrest, the other term that you might see with this is called sinus pause. Grab my pity. Down here, guys, see what happened with, it completely missed the beat, okay? What it should have been, and it simply forgot the beat. So there would be a P, Q, R, S, and T, what should have normally been there, but guess what? It's not there. And so now you're trying to figure out what's going on. And long and the short is that, like I said, it basically, the sinus node just says, you know what, I'm not going to beat. And it just kind of stops. And again, it fails to discharge. It's usually due to there's damage to the SA node itself. It might be from a medication overdose. It might be because the person bared down and increased their vagal tone. If they have fibrotic disease, it can also cause that. Most of the time, as long as it picks back up, it's usually fine. It doesn't cause any long-term problems. But again, if you're getting long pauses with this, that might be an indication that your SA node is damaged. And if your SA node is damaged, immediately you need to engage it again. And the best way probably is to use a pacing mechanism if you're seeing so much of that it's actually causing hemodynamic changes. That might be 2% of the time, maybe. So again, not usually a big thing, but you guys can see it. And again, usually if they're asymptomatic, most of the time they're fine. But if you just treat the symptomatic bradycardia using the algorithm, actually a atropine atropine actually works pretty good if their sinus arrest is so bad that it's actually causing hemodynamic changes. Alright, it's not break time. Hold on a second. Alright, yeah, there's a slide I wanted. Definitely, let me move my ugly mug out of the way here. Alright, so this one is kind of a little bit more exotic, and I see it about once every 10 years, and I've actually been in this rhythm. I can tell you, it's real. It happens. So Torsade's the point, or actually it's called Polymorphic Ventricular Tachycardia. This is usually caused by antidysrhythmic drugs that will end up causing this. The other thing that will cause this is if you have more than one spot making an irritable focus. Remember when we talked about VTAC? VTAC usually had one spot, it would fire off, and it usually fired off in this direction, and we'll talk about more about that with Axis. The problem with this guy is we've got 2 or maybe even 3 spots that are firing off. And again, it's going to create the wide bizarre pattern, but notice how these spots are changing to different things. And the key thing is notice how the points are down on these guys, but yet the points turn up and they'll go back and forth between those, okay? It'll go back and forth between it. This is actually a very lethal rhythm. And a lot of the times, again, the cure for this, by the way, is going to be magnesium sulfate. 1 to 2 grams of mag is IV push. The other thing is they are in this rhythm. Don't try to cardiovert them. It has a hard time picking up on that. Actually defibrillate them. Even if they have a pulse, you need to defibrillate these guys. Again, one of the biggest problems is once you defibrillate them, you haven't given them any mag, it may or may not get. If you put them in mag, usually the second you push the mag, guys, they will almost instantly come out of this. You might have to defibrillate somebody. It's actually, but again, Look for that turning of the points. Again, that's what exactly torsades means, okay? It's got a prolonged QT interval during the breaks. If I go back to here, notice how, again, it's got really long, the QT intervals here are really big. And again, the R to R is going to be variable in these guys. You don't treat it as standard VFib, and again, if the mag sulfate does not work, amiodarone 150 to, usually we go 150 in over 10 minutes. It works pretty good. I will tell you though that mag is your treatment here. Guys, the ones that I have actually seen, if they didn't convert by themselves, I can tell you that I had one that actually, it pops up on me when I had a stress test, and I go in torsades, and boom, and next thing you know, I'm back down to normal. As soon as I break stress, my heart rate goes back to normal. I go back into a sinus rhythm. So it's actually a really cool thing to see once you actually get to see it. All right, the last of the exotics that we're going to be talking about, and it's not per se an exotic. I think this one here is people are not used to seeing them, and so you have to understand what you're looking at. And these are artificial pacemakers. Now, artificial pacemakers, again, what they do is they run wires. They usually implant this in the upper left side of the chest, and it runs wires into the myocardium, and they kind of twist in, for lack of better terminology, or they'll suture the pads in. And what happens is that it actually provides a small amount of electrical stimulus to that part of the heart. Now, the old days, these wires actually plugged into they most of the time they did it to the ventricle. That's going to change, and I'll discuss that here in a second about what they started to do with it. So what this does basically is gives a ventricular rhythm. Now, this one here is a non-demand pacer. It is set to a certain rate, and when it's set to a certain rate, it's going to be equal. But here's the telltale giveaway, huge giveaway to a paced rhythm. Number one, they're going to have that spike. Number two, at the bottom of any LifePak 1215, and I'm pretty sure that the Zols do this as well, you're going to have an indicator that this is a paced rhythm at the bottom, usually an arrow. It will pop up. So if you're seeing that arrow, because again, if I'm looking at this, I'm going, wow, this is an accelerated junctional rhythm. No, it's not. It's got a pacer spike to it, okay? Or this is CPR. No, this is not CPR. There's a pacer spike to it. So again, the pacer spike is the key thing to be looking for, along with this guy down here. We got to look for that pace rhythm. All right. So again, it's usually that now they can have different pacemakers. Single chamber versus dual chamber, fixed rate versus demand, and we're going to talk about those. I got some examples to show you. And it's usually they give this when the heart's been damaged, and that's why or if they have a situation known as sick sinus syndrome. Sick sinus syndrome, by the way, is I would say would be an exotic, but basically it keeps going in, and the sinus node keeps going in and out. So you'll go from sinus tach to junctional bradycardia to ventricular tachycardia back into a junctional tachycardia. And again, that's because the sinus node is sick. It's not actually firing the way that it's supposed to. Okay. Also, if a patient's got a history of severe bradycardia, MI to the area, they may actually put in. Heart transplant patients usually have a pacemaker installed once they do it. Kind of depends on who the surgeon is. All right. So an AV sequential pacemaker. Now, guys, we talk about the normal beating of the heart, atria fire, ventricles fire. Okay, so somebody actually got smart and said, hey, wait a minute. We're putting in these pacemakers, so why don't we do that? Why don't we make it to where it fires the atria first and then fires the ventricle? So that's what they did. So they install, again, my heart here. This is my pacemaker out here. They install one wire into the atria. They will install one wire into the ventricle, and that way this one goes first, and then a little bit later this one will fire second. By the way, the new ones are all Bluetooth oriented, by the way, so they can actually make changes to the settings, just so you know. So this one here, again, is your atrial spike, and then the ventricular spike. And notice how, again, they're in sequence, okay? Now, we can't see hardly any atrial firing, but actually this little segment right here is the atria firing, okay? Now again, notice this is lead 3, but it would probably look the exact same on lead 2, okay? So again, that's an AV sequential pacemaker. Now, that's just indicating that it's firing on both chambers. Now, along with that, you can also have a demand or not demand pacemaker, okay? Again, it only works when it needs to. And as a matter of fact, in this one here, it's actually an AV sequential pacemaker that's firing, okay? So it's an AV sequential, but notice how it's got its own beat right here, okay? So that's a regular that's coming from the sinus node. Or as a matter of fact, what I'm seeing actually is a little pacer spike right there. But again, it only fires when it has to. But this guy is normal, okay? So that's a normal one. And this, again, it's sort of kind of, it tried to start to fire, but it kicked in, and then the actual ventricle, the pathways kicked in itself. So when you've got some damage where you've got a block or something of that nature, and it's not going all the way through, they will install a demand pacemaker. Actually, guys, our heart monitors are actually set usually to a demand pacemaker. So if you're using transcutaneous pacing, okay, transcutaneous pacing, actually we have a setting in there to say whether it's demand or not demand. Most of the time, ours is set to a demand pacemaker. So if I've got my heart rate set at 60 and the patient goes faster than 60, my pacer will say, hey, I don't need to fire. It shuts off automatically. If it drops below 60, it goes, hey, I need to fire. So the same principle applies with this case. So again, remember, by the way, these are installed pacemakers that we're talking about. Every now and then you might also see this on a transvenous pacer. That is usually a temporary pacemaker until such time as they can get in there and actually install a pacemaker. The other one is the ones we use is a transcutaneous pacemaker, which means goes through the skin. We don't actually, the thing is it requires more energy. These guys here that are installed, once they are installed, they take about a fraction of the milliamps, maybe 2-3 milliamps, maybe, to fire off the heart. Where we're going usually to 80, 100, 120, depending on how big the patient is. These things fire a really small amount of energy, okay? Now, unfortunately, every now and then we get this one where the pacer doesn't fire. We don't see the wide and bizarre. We don't see the capture wave, okay? So again, this is a capture right here. This guy right here is a capture, okay? This guy right here is a capture. This guy right here is a capture. This is our natural, right? That's a natural, that's a natural. But this is our capture. That means it worked. But what happens when it doesn't do that? That's where another major problem comes in. And by the way, usually when you have a no capture situation, it usually means you don't have a pulse. So again, double check. If you don't have a pulse, obviously start CPR. But the problem is that you're getting no myocardial response. So you're going to see a strip like this, and you go, wow, that's a great narrow QRS complex. Except for you're going to see probably these things down below with these nice little arrows. Remember, what we should be seeing is this behind it, okay? We're not seeing that behind it. We're seeing nothing at all. Zero, none, nada. We're not seeing it. If we're not seeing it, it's not capturing, which means the heart's not beating, and we're probably going to do a lot of work at that point. All right? So that goes over all of the exotics, if you will. And obviously there's a few little more nuances. By the way, one thing somebody might say to me is, well, what do you do for a not capturing pacemaker? Well, you've really got only one real choice, is to give them some sort of epinephrine. Because, again, that's probably the only way that you may get a heartbeat back. I can tell you that usually when I get a no capture situation, it's usually extremely bad. So by the way, problems that we have with our pacemakers, usually it's a battery failure. And then usually you get there and they're in either an idioventricular rhythm or a junctional rhythm. And again, it's usually slow. Again, we can transcutaneous pace these folks. You can get a runaway pacemaker. I've had a few of those. Yeah, those are scary. simply because they go nuts, especially if it's a sensing type. I actually had a pregnant female that had one installed. She went into AFib. The machine thought that the fibrillation waves are actually P waves, and actually put her into a form of ventricular tachycardia. So it would fire every time one of those fibrillation waves reached a certain threshold. Poor girl, and like I said, here's the other kicker to it: she was 8 months pregnant. It was a fun time. Okay. The good news is, though, we got her to the hospital. We deactivated the pacemaker, and it was a good thing. Displaced leads. The wire comes off, or the patch comes off where that happens. Actually, usually sits there and stimulates the myocardium. They throw a bunch of PVCs and can definitely trouble. Definitely, because it's going to sit there and irritate it. They're probably going to have to go in surgically and fix it. Even if they turn the pacemaker off, guys, the wire is still going to be touching the myocardium, and it's going to cause problems. All right. Make sure that when you're dealing with these pacemaker issues, there's one other thing. They carry a little donut, a little magnet donut. Most of the ambulances do, and the idea is that you put this magnet. It's usually made by Medtronics. They put it right on top of the pacemaker, and it forms such an electronic field that it kind of tells the pacemaker, "Hey, this is an emergency. Shut this off." Okay. If you've got one of these runaways or even a displaced lead, guys, you can throw that magnet on there, and it will stop them from actually having these things fire, either an implanted cardioverter defibrillator or a pacemaker. It will actually turn them off so that you can actually manage the patient. Again, it's kind of a rare situation where that happens, but when it does happen, it's like everybody's running for the magnet. They need the magnet. So again, know where your magnet is on your truck. If you don't have one, it's a good idea that you get one if your medical director will allow it. If not, you need to let the hospital know so they can go find their magnet. Usually it's sitting somewhere in the med room holding up pieces of paper. And again, it's a great magnet. It works great. So, but again, you can shut them off with that donut magnet. All right. Again, like I said, though, treat the patient. Definitely, any of these cases, treat the patient. Matter of fact, going back to this runaway pacemaker, I simply I started treating her for the AFib, and what we actually did is give her a gram of mag, and it actually worked very well. By the time we got her to the hospital, the tech was there. We disconnected we told it via the Bluetooth, hey, shut off. So that's the good news. All right, so that's it all for the pacemakers, guys. And again, we'll talk about the PEA on another video. So we'll see you guys later.